Session. Chatterjee is Professor of Biostatistics and Genetic Epidemiology at Johns Hopkins. And with him, we have today Dr. Sanjay Shete. He's the Betty B. Marcus Chair in Cancer Prevention and Professor of Biostatistics and Epidemiology at the University of Texas. We have Dr. Alka Dwivedi. She's a postdoctoral research fellow at the National Cancer Institute at Bethesda, Maryland. And virtually, we have two speakers joining us, Dr. Visvanathan, who's a professor of epidemiology and oncology at Johns Hopkins University and a leading expert in breast cancer epidemiology, and Dr. Shastri from MD Anderson Cancer Center. With this stellar panel in place, Nilanjan, I hand it over to you.
Thank you. It's a great pleasure and honor to both organize this session and have invite very distinguished speakers who are willing to participate both in person and virtually. Just as a brief introduction, I am a Bloomberg Distinguished Professor in Biostatistics with an appointment in Oncology and Genetic Medicine at Johns Hopkins. My own background is mathematics, statistics, biostatistics, like very involved in a lot of big data modeling related to genetics and cancer. And I was at the National Cancer Institute in the US for 16 years. But in the last 10 years, I made Johns Hopkins my home. And so this field, and I have a long-term collaboration in the Tata Memorial Cancer Hospital with the Cancer Epidemiology Group, with whom we have been doing epidemiology research for 15 years now, so it's a very long path. And so this area is very close to my heart. And as India population, as you may know, has grown and the young population is getting older, there will be increasing cancer burden for the population. And this is a really emerging problem. And so when the GKI invited me to organize such a session, and it was a real pleasure. So with that brief introduction, the way we'll organize is that I'm going to ask each of our distinguished panelists to give a brief introduction of their work, and then if they have any connection with Indian cancer research, and then we'll go through some specific questions related to cancer epidemiology, cancer primary prevention, secondary prevention, access to treatment, and data and AI research. And what can the institute like GKI can do to promote cancer collaboration, cancer research. And with that, so let's start with the people like who are here in person. Sanjay, you want to give an introduction for yourself?
Hi, good afternoon, everyone. My name is Sanjay Shete. I'm a professor at MD Anderson Cancer Center. Like Nilanjan, and we know a long time. I started as a mathematical statistician, but then got into more in genetic and molecular epidemiology and doing the genomic studies of head and neck cancer. But now I do more work on cervical cancer screening strategies to work, enhance the screening in particularly low and limited resource countries. I also work on the tobacco cessation and different and awareness. So one of the reasons I think people uptake is lower of screening because people have very low awareness of the cancer and cancer screening. So that's what I've been working last few years on this topic. And we have been working with some part with the Tata Memorial in training some of the junior investigators in there for screening and ways you can incorporate and do the follow-up for cancer survivors.
Alka.
Hello, everybody. My name is Alka Dwivedi, and I'm a postdoctoral fellow in National Cancer Institute, NIH, and since 3 years. And before that, I have been involved in developing indigenous CD19 CAR T cell therapy, which is a cutting-edge therapy which is approved here in USA, and I have been involved in that. And that was my doctoral or PhD project that I have done almost like 5-6 years. And now the drug is approved in India, and Indian cancer patients, they are getting. And the goal of the project was to make it affordable and accessible to our Indian patients. So currently the cost is less, and then patients are now getting and they have like access to that indigenous CD19 CAR T-cell therapy. And after that, I came here in like I joined NCI, and here my goal is to make it even more cost effective. So I'm working on making it more cost effective and more accessible to the cancer patients.
I just wanted to mention Alka because her work was named one of the most one of 100 most influential people by Time in public health in the last year. Okay, let's move on to our speakers who could not be here today online, starting with Dr. Kala Visvanathan.
So that's a hard one to follow, Nilanjan. But anyways, thank you first for inviting me. And also, I'm very excited by this, and it's an honor to be part of the day today. My name's Kala Visvanathan, and I am a professor in epidemiology and in medical oncology at Johns Hopkins. I actually have had the fortune here to create a unique position at Hopkins where I'm able to actually both conduct work and research at the population level in the School of Public Health, and I also am able to do things at the individual level from a prevention perspective. I focus on breast and ovarian cancer prevention, but I also direct the Cancer Genetics and Prevention Service. And I have to say, I was one of the early believers in the importance of prevention. And I'm so excited to see that that field has really started to gather momentum, along with many of the others here. And I really feel it is critical that we make a big difference in the next 10 years. And I think we have all the tools, all the people, and we really need to go in and do that. So very excited to be here, and thank you for the invitation.
Thank you, Kala. Surendra, if you can hear us.
Yeah, thank you, Nilanjan. And only thing is I'm still on the road, so maybe another 5 minutes or so I should be home, and then I'll be able to turn on my camera. But at the same time, if there's too much of background sound, please let me know. So my name is Surendra Shastri, and I currently serve as a professor in the Department of Health Disparities Research in the Division of Cancer Prevention and Population Sciences at the MD Anderson Cancer Center, Houston. I've had the privilege of serving as the chief of the Division of Cancer Prevention and Epidemiology at the Tata Memorial Center in Mumbai for 20 years. And then I came over and joined MD Anderson in 2018 and working there since. So I'm a physician researcher, physician service researcher, everything, a teacher, everything put together, you know. Sometimes life gives you those opportunities, you take them. So my focus is on cancer prevention studies, particularly interventional studies to look at low resource settings and provide, very effective but low cost interventions at these places. And the diseases, the cancers that I focus on are cervical cancer, HPV-associated cancers, HPV vaccine, also breast cancer, and tobacco-associated cancers. So those are my areas which I've been working on for almost 30 years now. And I'm really honored to be part of this very distinguished gathering and this distinguished panel. Thank you.
Thank you. So yes, actually, as this panel is about the emerging problem of cancer, and Surendra is one of the physicians who has actually worked in India at the Tata Memorial for a long time, and he has seen a lot of patients. So we'd like to hear from him, like if you can tell us briefly what are some of the emerging patterns of rates of cancer incidence, mortality, associated risk factors that are changing over time, both in terms of the sort of common cancers that we hear about globally, like breast cancer, prostate cancer for men, colon cancer, but also more regionally specific cancers like gallbladder cancers, which are very rare generally in the worldwide, but some parts of India is quite common, and another one is the oral cancer. If you can give us a brief overview of what's happening with the cancer rates and trends.
Sure, sure. Well, very quickly to begin with the last one, the gallbladder cancer is still an enigma because we get a lot of gallbladder cancers, particularly from the Gangetic belt. And we have been trying to find out what's the etiology, what are the causative factors. There have been several studies, but yet to find a meaningful solution to, do something to prevent it. So still working on those in India. There's a lot of GI cancers, that's gastrointestinal system cancers coming up from the northeastern part of India. The northeastern part of India had been kind of, cut off from the rest of the country for a long time. However, since the last a decade and a half, we have good data coming in from the Northeast. So we know that in the Northeast, for etiological factors known to us, dietary factors particularly, the GI cancers are very high in those areas. The rest of India, uh, among women particularly, breast cancer has now overtaken cervical cancer. So we see more cases of breast cancer as compared to cervical cancer. I don't know what's the real reason for that, because screening and HPV vaccination is not really happening in India. So there have to be certain other reasons as to why breast cancer is slowly coming down or at least plateauing. And cervical cancer is coming down and plateauing, and breast cancer is now on the rise. And that's where the difficulty comes in. As far as men are concerned, the lung cancer is still the #1 cancer among men, followed immediately by head and neck cancers, which is directly associated to the tobacco chewing habit among people in India. We get head and neck cancers among women too, but again, that's associated with the tobacco chewing habit. In men particularly, tobacco chewing plus alcohol put together is the reason for a large amount of head and neck cancer. So that's the kind of picture that we have in terms of where we get this data from. The Indian Council of Medical Research, with support over a long period of time from the International Agency for Research on Cancer, IARC, based in Lyon, France, have set up excellent hospital-based cancer registries and also a number of population-based cancer registries. However, the population-based cancer registries are far and less as compared to the population in India, and particularly in the rural areas. So that's where we come across the difficulty, and still working on those. So data, yes, very good with with the hospital-based cancer registries. However, that's going to be biased. Population-based cancer registries, which is going to be great. Still working on those. Thank you.
Thank you. We'll come back to the data question again, because that is, fundamental to everything we'll be talking about. But we heard about, some of the cancers that are, most common, like lung cancer, head and neck cancers, and HPV and cervical cancer. They have already known causes, and we know what are some of the major causes. So I'd like to hear from Kala, if you can address, like, what are some of the major challenges for prevention, primary prevention, like, for things that are already known risk factors, both globally, and what do you think maybe specific challenges in like the context like a developing country like India? And then if you can also talk about, maybe we are at a time, because of the changes in technology, there are new opportunities that we did not think about it before. So there is a time to maybe have some transformation in this primary prevention field. So if you can tell us a little bit about your perspective in these areas, that would be.
So I think, one of the terms I'd like to bring out here is, there are a few different terms. One is this sort of concept of personalized prevention, right? That's been a really big thing in the treatment field, and we've been somewhat successful already in sort of personalizing treatment, right? And I think a lot of us believe that we can push that to the prevention field as well. But what does that mean? I think there's 3 different aspects to that. So first of all, when I think about prevention now, it is across the cancer continuum. Primary prevention, right? Secondary prevention, which is early detection or screening, and then tertiary prevention, also thinking about prevention after that. So I think 3 pieces I'm thinking about is, one is what Nilanjan just said, is optimizing what we already know, right? So studies to implement what we already know, the risk factors we already know specific to different cancers in different areas, across cancers. We know there's many common risk factors. We think of obesity, alcohol, just to mention a few, smoking. We also think about shared risk factors across chronic conditions. Cardiovascular disease is a very big issue in India. So is diabetes. And we've done a lot of research now to think about what are those risk factors for cardiovascular disease or diabetes and cancer? How do they overlap? Can we do prevention approaches for those three? So I think that's another possibility. So one is sort of general, what I'm thinking about, general prevention across and doing studies to look at how to get it across to all the people and increase awareness and implementation. The other is optimizing risk, getting better risk models, trying to understand specific risk factors for different populations, thinking about the timing of those risk models much earlier, because cancers tend to occur a bit younger in the Indian population already. So let's think about when do we do these? Then identifying those at high risk and those at low risk. So the people we really want to give much more aggressive screening or prevention to, and people we want to give general ones. And really understanding it for different contexts. The other two things for prevention I just want to throw out there is India's got such a rich history of Ayurvedic medicine, right? And we should also leverage that history. We need more data on a lot of these agents. Some of that's happening in the US. We've done a lot of work on, for example, sulforaphane, but we need to get more studies to look at novel agents. And then repurposing medications. We've done a fair bit of work on aspirin and statins. It's challenging, but there are definitely times where this could be appropriate. And then lastly, think about prevention, think about early detection and liquid biopsies. And I should say all through all of this is AI and digital health. And the fact that we've gone from sort of a no phone evolution to a smartphone evolution really quickly. And can we leverage that digital technology both for education, awareness, prevention, screening, all these different strategies? And we've started doing some of that even here. And I think that's very possible. I want to make one last comment, is this term interception. This is a new term, but I think a really important one for the Indian context. That is, once you have some abnormality, either a pre-cancer lesion. So instead of thinking about how to prevent fully from the beginning of cancer, can we prevent when it's just starting? So there's a pre-cancer before actually can we go in and target? And I think that's another exciting phase that we should look at and see, particularly the fact that these cancers are happening early. I'll stop there, but I think that gives you a little bit of a flavor, hopefully, of how we're thinking.
Yeah, that is a real nice segue. And people who may not be very familiar with the cancer prevention effort, we want to think in a more of a continuum, like the where we can beat cancer, and starting from the beginning. First, let's think about primary prevention, which is about stopping cancer from the even just from the very early on. And then we talked about maybe detecting early markers of cancer or precursors of cancers, and we can detect those early, maybe you can do something at that point. And then the next thing comes in that continuum is very important, is cancer screening. So how if the cancer is developing, how do we detect that early? And that's what we think about in terms of continuum. So I would again like to throw back to Surendra about what if he can tell us about, in terms of cancer screening, what are the common modalities of cancer screening that have been adopted for India, and what are some of the challenges has been, and if there are any low-hanging fruits where we can contribute.
Yes, thank you. So, there are challenges and problems both that we face in India, we still face in India. But those are not peculiar to India. Those are problems which are, I've seen in most low and middle income countries. So that's something, we will have to look at and learn from other middle income countries too, as to how they are tackling. Some of them are good, but I can tell you very briefly. Sorry. There's a lot of background sound. So, can I come back in about 2 minutes, because there's a little background sound. Can you hear the background sound also?
You can come back later.
Okay.
If
I can come back in about another 5 minutes or so, that'll be good. Thank you.
Okay. So The continuing theme is like that I think came up multiple times, that this might be a time where we have a lot of opportunities because of India has a lot of indigenous talent in terms of IT, software engineering, AI in particular. And then my next question is going to be towards Sanjay about what he as a, who has been a statistician and worked in cancer epidemiology and genetics. If he can tell us a little bit about what he sees opportunities for using AI technologies and data science and to solve some of this problem to whether primary cancer prevention or getting better data or cancer screening, which is a secondary prevention.
Oh, thanks, Nilanjan. So I think, as we know, that India is really good. There is a tremendous talent in computer science, mathematics, statistics. And now with the computational tools and all the smartphones, there is a tremendous ability to collect the data that we had never done it before. But I think when we talk about how do we use these tools for prevention, primary prevention, it comes is like in a lot of low awareness. You ask how many of people have done cervical cancer screening. First of all, most of the people in Indian setup and even in US don't want to talk about it. When it comes to vaccine, like an HPV vaccine is freely available in this country, the uptake is 60%. So that means 40% of the age eligible people are not taking the vaccine. So there is a hesitancy. India does not have the hesitancy as a much issue, but it's not that vaccine is not as a part of the national immunization program. That means you have to pay for it, which is again a barrier for it. And so I think there is AI is going to help you so much, and we need to have really good data sets. So as Surendra mentioned, there's a lot of efforts in collaboration with IR that we have started some cancer registries, hospital-based and some population-based, but the coverage is very, very low. And so we'll not be able to, AI is not going to solve the problem. AI needs the quality data. AI needs the reproducible data. So we need to make sure that our data is high quality and not just, and also one of the biggest thing that we talk, every opportunity I get in India, I talk about is the data sharing. We need to, this is something I think the Institute really GKI can take on, is the data sharing. If you look at in the US, if you want to get Massachusetts, the number of cancer, the breast cancer, there is a cancer registry and you can access the data very quickly. There is a protocol you have to do it. You can't just go and click on it. NCI, for example, today morning released the large amount of cancer prevention screening knowledge questions in the US, and you can get it on one single click. I wish that happens because there is so much talent there with the statistician, computer scientists, but really getting access to that data is very, very difficult. And it becomes a barrier to utilize that data. So how are we going to use that data? Because really we need to identify which pockets are not doing the screening. Where are as Surendra mentioned, Northeast, there's a low uptake. Why is it? So we need to know that one. If we don't know the answers, AI is not going to help us on that one. So I think the sharing and collecting the quality data is the only way we're going to reap the benefits of AI and the smartphones that we have. Because all of us have a smartphone in India, many people have it, but where is that data going? And who's curating that? Because unless we have that information, we'll not be able to get out the quality output from that one. So I feel like the data sharing is really important. The talent-wise, there is no problem. There's a tremendous, if you look at even the top mathematician, computer scientists, statisticians in this country, India has many, many of them. But we just need to get that connection to them with a really good data set.
Another thing I find
Thank
when I
you, Nilanjan. I'm back.
Yes, I'll throw that back to you in a second, but I just wanted to add, I'm Sanjay, other than the talent, low indigenous talent in India, what I find is Indian population very quickly adapting to technology. If you go to India nowadays, I feel like the use of apps or digital technologies is more than the US now. And so I feel like, if we can, there is an opportunity there where, if the people like us, people like GKI, and they can put initiative to develop apps so that primary prevention or secondary prevention becomes more easily accessible, population is hungry for that kind of thing. And because they are very easily want to, they have the access to all these kind of digital tools, there is probably some opportunity.
Yeah, just to kind of add into that one. So for example, MD Anderson, we have some apps that we follow. Most of the head and neck cancer patients, actually, they go home, the mouth hurts, so they don't drink water. So they come, actually, they are dehydrated and they come to the ER. So now we have the app and that reminds them to drink water. That it's a simple intervention, reduces tremendous amount of the healthcare costs. And so countries where India, like where there's a limited clinicians and going to the ER, I think these kind of interventions are really important to even as a part of the cancer survivors program.
Okay, Surendra.
Okay. Yeah. So
About
sure.
cancer in India, and what are some of the existing nationalized programs, and where do you see some opportunities for developing new programs?
Absolutely. So, India was among the first countries in the world to start a national cancer control program, 1984. As early as that. However, the progress has been, abysmal. It has been very, very slow. Just about a decade back, there was a new initiative that came up, and that was with cervical screening, with visual inspection with acetic acid, breast cancer screening with clinical breast examination, and oral head and neck screening with simple oral examination. This was a pilot project that the government of India embarked upon in 100 districts and then slowly expanding to other places. So this is a program which is on at this point of time. However, there are a lot of fallacies out there which need to be looked at. For example, yes, for cervical screening, 30 years is a great age. It starts at the age of 30 for women. But for breast cancer, 30 years is not, the right time to start clinical breast examination, because you're going to find a number of, swellings or bumps or whatever, and at different periods of the menstrual cycle, and that creates a lot of unnecessary anxiety. Nothing has to be done. It overloads the health systems in such a way that once something is found, you need to go for a diagnostic confirmation. So it creates a little issue there. So if it is high risk population-based screening, that is populations which are likely to be at high risk for particular cancers, makes sense because India is such a large population. You can't possibly, provide services for everyone across the country. Two, it's important to understand that the cancer care, right from education to survivorship, is a whole continuum. So when we start educating people, empowering people to understand what is cancer and how you can prevent cancers, great. But when we talk about screening, then screening services need to be available, and screening services need to be available all over the place. Now, you have screening services in some places, but then after screening, what? You need to have diagnostic services. So again, diagnostic services, diagnostic confirmation of the screen positives are not freely available. Once a person is confirmed as a diagnostic positive, then you need to have treatment facilities. Again, where do they go for treatment? So unless the screening services are dynamically linked with referral services to centers, there are centers. There are cities, there are district centers where a good level of treatment can be carried out. Unless they are properly linked, and there are methods. There are healthcare workers who could play a great role in linkages and follow-ups and things like that. However, that has not been planned as yet. So there is an issue there. There is a lot of funding available now through the PMJ. Where people of low income can be treated almost free of cost at these centers. So that needs to be, looked at, and how it could be best utilized. And the third thing I would like to point out here is, it is not necessary for India or any country or globally to have a single cap on all heads. Yeah, it's not easy that a single cap fits all heads. So there will be situations, there will be regions, geographical regions with different resource levels. So we need to develop guidelines, and we have done this. I mean, from through the American Society of Clinical Oncology, we have done this for different cancers, for cancer care also. So you have village level, you have district levels, which have different resource levels, and you can develop guidelines for those, for screening, for diagnosis, for treatment. Then you have cities which have the apex level, what you have in the US today or in Europe today. You have at the Tata Memorial Hospital or the All India Institute of Medical Sciences within the next couple of months. So you have that level of treatment too. So we need to have resource stratified guidelines for diagnosis, for screening, for treatment of cancer, and which is possible, which is something I think the Gupta Klinsky Institute can play a big role of getting experts from India and abroad, sitting together, seeing what are the best practices, that can be adopted at different resource levels. So that's something I think the Gupta Klinsky Institute can really play a big role. Thank you.
Thank you. Thank you, Surendra, for that. So yeah, so I think Surendra mentioned a very important point that, okay, we can try to bring cancer screening to people, but then what happens if the people are screen positive? We need to have a good referral for diagnosis. And then once you have the diagnosis, how about cancer treatment access? So my next question is related to actually cancer treatment. And I would like Alka to address this question about what do you think about, given your experience working both in India and then after moving to NCI, you have continued to work in India to make treatment more accessible. What are some of the barriers of treatment access to common people, population? And then given your success recently about making CAR T cell therapy more accessible, do you see that could provide a model for cancer treatment access more generally? Or if there are other models you can think about?
Yeah, so if we talk about the treatment option and the challenges, the first thing is the workforce challenge, which we see in India, that there are like around 1 million cancer patients, there is only one oncologist, which is available in India. But however, in US, it's like 161 oncologists per 1 million patients or 1 million people. So that workforce shortage is there in India. And other than that, the most important is the cost. If the treatment is available, even in India, but that the cost is the major barrier. For example, the CAR T, which we developed in India, the cost of the CAR T therapy, if we talk about in INR, it is around 4 to 5 crores for one dose, and like $500,000 in US. Just one dose, so which is like completely unaffordable to our Indian patients. So when we looked at the price, and then because when we started that work in India at that time, it was the clinical trial was running here. It was not approved, but in 2017 it got approved, and the price was like $500,000, so which was completely unaffordable to our majority of the Indian patients, which come from the middle class family. So what we did, so we developed our indigenous product. Instead of taking from the Western countries and running the clinical trial, we developed our indigenous product, and we collaborated with so there was a collaboration between the academia and the clinic, as well as the pharmaceutical company. So we had this three collaborative efforts, and then all three of us made this indigenous CAR T therapy available for our Indian patient. We made it because we developed as the indigenous. So that was because we had everything, all the process in-house. So that was the point where we reduced the cost. And because for CAR T cell therapy, it is available for leukemia. So what we did, so if first you have to, it's a cell therapy process. So you have to engineer the T cells of the patient and then re-infuse back into the patient so that it can fight with the cancer cell and kill the cancer cell. So it's an engineering process. So it's a multi-step process. So we did all the multi-step process in our in-house to reduce the cost. So that was I can propose, this is the entire model which we use, like the partnership between the academia and the clinic, and the Tata Memorial Hospital was one of our clinical trial center. So, and the clinic as well as the pharmaceutical company, like we have this ImmunoAct, which is our spin of our IIT Bombay. So IIT Bombay and the Tata Memorial Hospital and the Immunoact, we all three we together like joined, and then we brought this CAR T cell therapy. So this was the model which India can use as a like for other therapy as well, not only for the cell therapy. Immunotherapy, it can be used for in other cancer prevention as well. So still we are like not only limited to the leukemia, we are still trying to bring it for the solid tumor as well.
Just to add on that point, I mean, that's, bring a very interesting observation that this unique collaboration, between academia, industry, and the clinical center that made this possible. And it's very new, right? I don't see that kind of collaboration more broadly. So I was wondering, do you see a more movement towards such collaborations happening in India, or at the initiative from the government level, or the organization level to kind of encourage those kind of collaborations, or what need to happen to make this your model to replicate many times?
Yeah, so there are like government fundings which is available for the industry and academia, like the joint funding which is by the government of India. So they are providing funding for the academic as well as the pharma companies to run like the joint grant, and then for these innovative treatments. So those are the fundings which is like kind of government of India is providing, so which might be beneficial for the.
Yeah, that seems like in a very good place for institute like Gupta Kinski to come in to be the catalyst,
exactly,
right? To be that to make that happen more often than has been past.
I think just to add, I think like what Alka said, I think like even in India as well as in the US, high percentage of people go bankrupt because of the cancer care cost. And I know people saying that, oh, I sold my land because I need to take care of my son. And I think that's where like the second once, we pass the prevention stage and you have the cancer, I think bringing not relying on the Western world and then just getting it directly from Western, it's never going to be accessible to anybody. Yeah. And I think that's where like a lot more innovation on this topic is really needed. So congratulations for your work.
Yeah, thank you. So because the most important is the developing in-house. If we develop the clinical like the treatment or whatever the drug in-house, that will make it more cost effective. But I know for that we need money, but yeah, so we can maybe industry can help us to do the innovation or the funding for developing these treatments. And I would like to mention that the CAR T therapy, which is available right now in India. So here it is around like $500,000, and in India the price is like 4 to 5 crores. But right now we are like providing these CAR T cell therapy for leukemia patient is like 5 lakhs, like $50,000 only. It's like reducing the cost of like only 10%, 90% reduction, and only 10% of the cost of whatever it is. So that's the huge difference we brought because of developing it in-house and having it in India.
Thank you. Yeah, we're nearing the end of the discussion, but I think it'll be good to end because it is a panel discussion from Gupta Kinski Institute. I would like to hear now from each panelist if they can briefly have one thing, where I think they want Gupta Kinski to invest or catalyze something. What would that be? And so let's just go around and maybe start with Kala, if you want to have your one pitch about where Gupta Kinski can invest.
Yeah, can I say two things? Just data, as everyone else said, right? So we need to have the same type of cohorts and data and pulling observation data that we have outside India, like in the US, which US is a struggle, but I'd say Europe or Australia and globally. So one is data, and then two, an enormous potential for, along with drugs, to think about biomarkers and genetics. Even in the US, germline testing, for example, was unaffordable, $4,000. Now it's $100 or $200. We can do even better in India. So I would say collaborations with technology and companies and data, both things is where I think we should put our efforts.
Surendra.
Hello.
We can hear you.
Okay. So quickly again, maybe two, but not really two interconnected. I mentioned that resource stratified guidelines is something that really useful for all low and middle income countries. So Gupta-Klinsky can work on developing resource stratified guidelines, 2 or 3 levels of resources and guidelines for each of those levels for India. And I'm happy to participate in that kind of initiative. And then to appropriately train people at different resource levels for carrying out those functions. So these are two things which I'm pretty sure and hopeful that Gupta-Klinsky can come in and take a lead role in, and can support the country's cancer control program in a big way. Thank you.
Thank you. Sanjay?
I think that, so as I previously mentioned, the data is another thing, but I think like cancer registry by default, that means these are cancer survivors. But I think the general population, even awareness of the cancer, like do they even know about it? Or do the people talk about the cancer? And I think that's a major campaign is needed, like, gutka use. I had like, by the way, this is the, something outside, like I remembered, last time I had gone India, somebody told me that, oh, I have Ayurvedic gutka, and it will not cause cancer. Like this, it resonates some people, and people are going to do this one, but because they follow it, because somebody tells them. So I think like the lack of awareness, lack of understanding of what the cancer is, and I think we need really major awareness, and also survey is doing and assessing, like with the electronic data, send the survey and ask them simple question. Do you know that? Do you think like the gutka can cause your cancer? Or do you think like, alcohol can cause cancer? So all kinds of this awareness and regular surveys of the representative population is needed to know really what is people before they can take the any cancer screening uptake, because they probably have no awareness. And cancer is, the old age disease. Typically, that's people's belief. And so I think changing that belief and collecting regular data is really important.
Thank you. Alka, you get to the last word.
Yeah, so I would like to mention that the GK2 can be a bridge between the academia and the pharmaceutical companies to bring these innovative treatment in India. And the other thing, like for example, these new cutting edge research like immunotherapy. So there we need a skilled people. So maybe if GK2 can help in the training staffs or the researchers to make the CAR T cell or the entire immunotherapy platform. If the GK2 can help in the training process.
No, these are really some excellent ideas, that we heard. We'd definitely like to think about this I'd like to bring this up into GK2 leadership about how to launch new initiatives. But this is a fantastic panel and discussion we had. And I would like to thank you again for participating, and some of you actually came pretty far away. And thank you, Kala and Surendra as well. With that, we'd like to close this session, and thank you for your interest.
Thank you.
Thanks, everyone.
Thank you.
Thanks, Nilanjan. I think that was good.
Yeah, very good. Really.
Okay, so such an amazing talk, and I would like to thank Dr. Nilanjan Chatterjee for arranging this line of amazing speakers. Thank you.
Sanjay, you can take this on students.
I can take his and I can.
Absolutely.
I will charge him money. Surendra, I have yours.
Dr. Alka, Dwivedi. Thank you for this wonderful talk.
You put the screen the other way.
Okay, right here, ready? 3, 2, 1. Thank you guys.
Thank you.